Our next section will be on, where we shift to endocrinology, and I'm here with the esteemed mentor and role model to so many of us, Professor Bruni, who's author, mentor, role model, friend to many of us, and just so honored to share a podium with her. Okay. And our first speaker, and I'm Ellen Rome, and our first speaker is a professor of endocrinology who works here in Belgrade. He's an author and editor of the international books on PCOS, Professor Đuro Makut.
Thank you very much, dear Chairwoman. So I have a great task to talk about 15 minutes. If we are 5 minutes late, and I prepare 20 minutes, so it will be really a task. So I will really try to be as quicker as possible, but not too quick, not to understand what I will talk about. I'm the adult endocrinologist, and I'm just welcoming you in the name of the European Society of Endocrinology Special Interest Group for the Polycystic Ovarian Syndrome. And I will talk about something which is the standard in the adult PCOS, but I will touch some points which are related to the adolescents. So I don't have anything to disclose. And the PCOS is considered to be the most prevalent endocrine disorder in the female population, about 10% according to the NIH criteria from 1990. But if we use the Rotterdam criteria from 2003, and this year we are celebrating 20 years of these new criteria, we have about 24%. So it's a huge population, and you will see I will stress and point on the metabolic outcomes of the problem. So what are the controversies within the diagnostic criteria? We have lots of definitions, I can say in a few decades, but these are the key ones. So you will see the first one, which is from the National Institute of Health in 1990, that we have chronic anovulation and clinical or biochemical signs of hyperandrogenism to fulfill both to be the diagnosis of PCOS. Then, 13 years later, it was established that the morphology should be also included, and that's why we have 2 out of 3 criteria to be used. Any 2 of those 3, and that's we are then separating these PCOS into the phenotypes, and we have more metabolic phenotypes and some of those which are more reproductive. And the Androgen Excess and PCOS Society in 2006, they put the androgenism as the hyperandrogenism, the key element that should be fulfilled always, with the addition of another one. So it's really complex, but we have to monitor the patient and to see if they are fulfilling at all. But what's going on with the adolescents? So we have to consider the evidence of anovulation, of hyperandrogenism, biochemical evidence of hyperandrogenemia, and the polycystic ovarian morphology. So what combination of criteria are appropriate for the diagnosis of PCOS? This is one of the key questions, because in the last 20 years we are actually discussing, and mainly between the pediatricians and the endocrinologists and also gynecologists. So this is important to understand how to evaluate. So this is something which is recently launched by the group of the American investigators that are very prominent within the Androgen Excess and PCOS Society, Selma Wichel, which is the pediatrician from the United States. So they propose that between the menarche and the first year post-menarche, we actually do not have to talk about the PCOS, which is completely logical. I mean, it's really stupid to talk about that. Then after the first to the third year, we have to combine. You see, down there at the third line, you have always hyperandrogenism, clinical or biochemical, with the menstrual cycle irregularities. That should be, and that are always much more worsened in the first few years, while at the third year, up to the 19th year of age, we have menstrual irregularities that are very close to the adult diagnosis of what is the irregular menstrual cycle, and then to continue in the adult period. What is not recommended is to use the pelvic ultrasound for the diagnosis of PCOS in adolescents. So this is the proposal. So what are the criteria? And the criteria which were set in 2015 from the side of the Pediatric Society is to have the moderate to severe hirsutism that constitutes the clinical evidence of hyperandrogenism. But what is important? It is important to know with what laboratory you are working. So that's why I put this slide, just to stress on the importance of different diagnostic approaches. Today we have a huge confusion about how to diagnose. Nobody is controlling the tests. We don't have the settings according to the nations, so we really have a big problem. But if you can see here in this slide, on the upper part of the slide, you can see the excellent correlation of the radioimmunoassays and the Ferriman-Galway scoring system. Below, you have the liquid chromatography, mass spectrometry assays, so they are not showing any specific, much more higher beneficials to the diagnosis, and it's not used in the ordinary clinical practice. So this is very important to consider. So even the radioimmunoassays from 60s and 70s can be very, very useful. And what we proposed in our special interest group some years ago, it is how to evaluate. So you have to use the total testosterone assay, not the free testosterone, which is a great mistake. Don't use the free testosterone as the kit or as the diagnostics. If it is elevated, we are talking about the hyperandrogenism. If it is normal, maybe, or looking normal, you have to oppose it with the SHBG and then to see if it is actually normal or lower, and then you can say, well, this is the bioavailable increased testosterone. So you have always to put it against the SHBG and then to see the free testosterone index. This is one of the key messages from the point of the adult endocrinologist. So about the morphology, you see, up to 40% of normal adolescents meet adult PCO morphology criteria. So that's why it is really problematic to analyze and to say, well, this is really polycystic ovary or this is not polycystic ovary. And that's why it was proposed that until definitive criteria, the ovarian volume of the maximal ovarian volume of over 12 milliliters could be considered as enlarged, and the follicle count should not be utilized to the diagnosis in adolescents. So this is very important, to look on the volume and not on the follicular counts. In association with this is the anti-Müllerian hormone. So we have some differences, and there is also a huge diversity among them. So this is one previous study that shows that the cutoff value between the normal, in this group, between the normal girls and those that have PCOS is about 3.4. So this is very selective and specific for some populations. But very recent meta-analysis of the data in the last few years show, this is the Japanese study, but showing excellent ratio about the importance of the anti-Müllerian hormone. You can see that it is about 3 times higher in PCOS young girls than in the normal, the non-PCOS population. And the cutoff value, which is proposed, is now higher, 6 to 7, and it's approaching to the adult level of the anti-Müllerian hormone. So because of all these diversities, it's not recommended to use the anti-Müllerian hormone even in the adult population. So this is also very important to know. You can use the anti-Müllerian, but not use as the definitive diagnosis. But we have also some very known endocrinologists that propose something which is, on my point, something that should be considered, that if you really want to say someone has the adolescent PCOS, you have to fulfill all 3 criteria, but to be firm. And this is the paper published by Enrico Carmina, who is one of the leading experts internationally recognized. And he said that the diagnosis, the full diagnosis, which is the phenotype A, according to Rotterdam, should fulfill all 3 elements. So what are the origins? Origins are somewhere between the lipids. So you can see that the girls that have PCOS has larger adipocytes and lower adiponectin levels, which is turning into the increased insulin resistance and increased inflammation. So we have bigger lipid cells, and accumulation of lipids is worsened inside. And that's why the Australian authors came to the idea that probably it will be very good to have the general approach to the PCOS by the influx of genotype or environment, and then on the prenatal androgen exposure, and then going into the reproductive consequences on your right-hand side part of the slide, going into the anovulation and infertility problem, and on the left-hand side you see the metabolic problems leading to diabetes and other metabolic consequences. But which are they? This is a very complex slide. I will just turn your attention into the first part. So the adolescents, hirsutism, acne, obesity, irregular cycle, hyperinsulinemia, even depression and anxiety. So this is very interesting. The girls are really suffering. It's not an easy task to carry the polycystic ovaries that are presented by the acne or hirsutism or whatever. So we have really to have the teams for the treatment of those ladies. Metabolic derangements are a lot of them, and this is one of our early studies that shows that there is the decrease in the HDL cholesterol and increase in triglycerides. You should never use the reference values, because if you go there, then you will be completely stuck and will not understand the issue. So they have elevation of lipids, some of those. They have the increased oxidation of LDL. So this is one of the studies that we published about the oxidation, meaning that we have direct impact on the blood vessels. And then at the end, in the last square, you see the insulin and HOMA that are increased. So insulin definitely in comparison to the controls is elevated. Even furthermore, the metabolic syndrome, if we consider the adult patients, but take into the consideration that we have the epidemic of the adolescent and children's obesity, so something like this will happen. So this is the study that we conducted between Greece and Serbia, and we showed that there is the increased metabolic syndrome prevalence in the PCOS group. So very clearly, we have a pool of patients that are going to develop beta cell dysfunction. And on the first part, you see 75% of the normal capacity is related to the normal ones. But then if you go to the left side, you will come to the PCOS family history. So if that case has a family history of PCOS, like her mother could not achieve pregnancy, whatever, so you see that the insulin sensitivity dramatically decreased. So PCOS is per se associated with insulin resistance. So we do not need by definition to deliver, tests, whatever. We must know that they are insulin resistant. That is really turning us to the conclusion that we have lots of increased cardiovascular risk factors, but we do not have the events. The studies are very complex. You really could not follow the patient during the lifetime for 20, 40 years to say, well, this is actually the event that happened because of the existence of PCOS. That's why we need longitudinal studies in future. What is true is that we have type 2 diabetes, which is much more frequent, and you see those lines are showing this. So the ladies that have PCOS have, in comparison to the other cardiovascular events shown here, or the general population, non-infectious conditions like the cancers and the other types of mortality, they have really increased percentage of diabetes. And this is a recent study that we published between the 4 countries in Europe, Poland, Serbia, Bulgaria, and Greece, in a huge population of Caucasian women. So we tried to analyze or to say, well, can we use only the basal glucose level to say, well, this is a problem with this lady? So if you take a look on the second column, you will see in the PCOS that they have even higher impaired fasting glucose, so elevated glucose basal, but also glucose tolerance is impaired, and finally the type 2 diabetes is more frequent. What is more interesting for me is this slide that is showing us in the first part we have the type 2 diabetes, the second one is impaired glucose tolerance, and the lowest one is impaired glucose, fasting glucose. And you see the differences. The blue lines are showing the young population between 17 and 22. Let's say that this is your population. The second one, the orange, is from 23 to 30 and then over 30 years. And what is interesting is the first part, the first line on the top, is showing that the obese adolescents are more prone to develop diabetes in comparison to the other groups. This is really of importance, and we are coming into this phase of the really worsened health condition of our young ladies that we are following. So remember, adolescents are at the increased possibility to have diabetes. What are the therapeutic aspects? We have to treat either anovulations through the menstrual cycles, hyperandrogenemia, or insulin resistance, but this is also complicated and quite complex with the adolescents. Okay, you don't mind if I continue for 2 minutes, sorry. Can you switch off this? Okay, so the effect of lifestyle intervention on the first place is of the ultimate importance. So we have to introduce the lifestyle intervention and then to improve the intima media thickness as the outcome, final one. So the normalization of different aspects of PCOS and hyperandrogenemia is leading toward the decrease or attenuation of the cardiovascular risk factors. What about the obese adolescents? We have to focus on metformin. Metformin is the only approved compound that could be used as a drug. So it could have some influence on the menstrual irregularity, but more influence on hyperandrogenemia, less influence on lipids, and quite a successful effect on body composition if you consider, if you follow also with some training with those young ladies. What about the non-obese adolescents? Again, we can use metformin, but we can use the androgen receptor blockage, so flutamide or spironolactone, or the combinations, which are very famous one, coming from Barcelona, from Spain, from Lourdes Ibanez, that patented, I can say, launched different studies. So you can see that in combination of small doses of different things, like the pioglitazone plus flutamide and metformin, is showing a good effect on the metabolic outcomes and even on the inflammation factors. So you can consider this, but this is not officially approved. These are actually some investigations. What about the metabolic phenotype in general? So we have to introduce the physical activity, dietary counseling, etc., insulin sensitizers, in the recent period GLP-1 receptor agonists, and bariatric surgery. But this is mainly for the adult persons. But what is an excellent example of this is my PhD student coming from the institution who is organizing, who is the host of this conference or this congress here in Belgrade. So we performed the high interval intensity training together with the nutrition effects. And so you can see in the lower part of the slide here, when we use both combinations, you can see the perfect lowering of the insulin. And this is with the statistical significance. So just simple interval training, which is not the continuous one, together with the diet, could be perfect. What about the metformin? It has pleiotropic effects. We have lots of effects of metformin, but I will stress your attention on the ovaries, and you will see that they are, as I told before, nicely influencing hyperandrogenism, insulin resistance, T-cell cell proliferation, etc., etc. So very nice outcome on different sides, on the maturation of the all sides, but also on the decrease of hyperandrogenism. But what you have to take into the consideration, the metformin use is approved for the treatment of glucose intolerance. Why do we do not have the clear benefit of using the treatment of hirsutism, regular menstrual cycles, etc.? So don't use metformin by definition. You have to assess the patient, to talk with the patient. This is really important. Nobody is talking with patients. So the inositols and the story about new compounds, this is the supplement, actually does not have the category of the drug, but it could be useful in some very marginal situations when we have some deteriorations of insulin sensitivity. You can see the myoinositol, but also the dihydroinositol are effective and affecting on the improved glucose to insulin ratio. The HOMA, but also nicely affecting, especially myoinositol, the oogenesis. So this is the one of the last slides. These are the new, how can I say, guidelines how to analyze the risk for the development of PCOS later in life. So if you have these things that are in the boxes on the first line, like isolated menstrual irregulation but without hyperandrogenism, or hyperandrogenism and regular cycles, and hyperandrogenism and menstrual irregulations in the first year, etc., you have to consider that this adolescent girl is prone to develop PCOS. That's why you have to follow her and to recommend healthy style life, I can say. And this is the last slide. So these are the conclusions for the adolescents. So the diagnosis should be based on the presence of clinical and biochemical hyperandrogenism and irregular menses at least 2 years after the menarche. PCOS morphology on ultrasound is not a diagnostic criteria. At risk are those with irregular menstrual cycles without hyperandrogenism. We have to follow them. So these are the patients for your life. If you start with them in adolescent period, you will follow them always. And therapeutic options, lifestyle modification, I will stress for the adolescent this on the first place. And then, of course, we should not forget the oral contraceptives. I did not want to speak about the reproductive outcomes. I stressed only on the metabolic ones. Thank you very much for your attention.
Okay. Next we have Professor Devorah Bauman, who is director of the first PAG training center in the Middle East. She is the head of PAG services and director of Bat Ami Center in Hadassah University, Jerusalem. And she is a past Fiji board member and coordinator of IFA.
Thank you so much. I'm a doctor, just the third degree, but thank you. Maybe I'll attend it one day. And I would like to thank Zoran and Paul, all the organizers, for having this opportunity. Beautiful Belgrade. And up to that's the happy news. Now I'm going to the sad news, because it's quite pessimistic what I'm going to tell you. I have nothing to disclose. I don't know if it's good or bad. However, I want to tell you about epidemics. All of you know the COVID epidemics, right? And it was for 3 years and it stopped. The declaration that it's no more epidemics, but we have other epidemics which is just growing, and that's epidemics of obesity in general population, but also in children and adolescents. And if you can see, can you see my no, okay, anyway, you can see that it's rising, and then about in the beginning of 2020, there was a little dip. And that because many countries went for interventional programs in schools and everything, changing the food in schools, making more sport and etc. And they were really happy because they see this decrease. But finally, it just go up and it continues. And the even more sad news is that we have, So what is important in those 20s that all the interventional programs were intervened in schools is that after stopping this intervention of schools, this is a work from United States, they looked for children in higher socioeconomic level and lower. And I don't know why, but criteria was the education of mother. Yes, if she did only high school or less, or she was the first academic degree or more. So if you can see that in a high economical status, they continue to lose weight, but in the low one, they just go on and rise the obesity prevalence, and that's because interventional programs are governmental and supported. But once they stop, you have to go to gym, it costs money. You have to go to swimming pool, it costs money. It's not for people who are low socioeconomic income. So the bad news, really the bad news, is that we have the forecast published in 2012. And then we thought, okay, we have 20 years to do something. But now it's approaching. We are 23rd. Okay, so if you can see that in 2030, the obesity rate in children and young children will be in about 40%, and the severe obesity, which is even more, will be approaching more than 10% in the population. So when we talk about obesity or fat accumulation, we have to understand there are different kinds of fats. Okay, we have the superficial subcutaneous tissue, we have the deep subcutaneous, and we have the visceral adipose tissue. Okay, and under the influence of estrogen, as it comes in women, usually the fat that accumulates is superficial, and that's why it looks like a pear. And under androgen, it's more visceral fat. Okay, and the one who is correlated to metabolic derangement, as Professor said, is the visceral, not. So many young girls that say, I'm fat here and I want to lose, you can tell her there is no risk for metabolic disease. The risk for metabolic disease is the visceral one. And we know that it's under androgen influence. So androgen causes accumulation of this kind of fat, and we have works from transgender people who are male transgender, meaning they were female, and they start to take testosterone, they accumulate this kind of fat. And we know that the estrogen-dependent fat is not correlated to metabolic diseases, and on the contrary, those women with higher accumulation of this kind of fat has lower hemoglobin A1C, have better metabolic performance. And what is so bad to be fat? If we don't talk about cosmetics, the problem is that when we have a lot of adipocytes, accumulation of fat tissue, it causes what's called sustained low-grade activation or inflammation, and this one is causing many times, it's causing vascular damage and inflammatory state continues, which is really bad for most of our organs. And we know today that obese children and adolescents has a lot of comorbidities. There is this publication from 2019, showed 29 comorbidities that those children will achieve in a very young age, like hypertension, diabetes, and et cetera, et cetera. So we will see, if the forecast will be true, we will see people at the age of 30 with myocardial infarction, with maybe amputation of legs because of diabetes, and et cetera. I'm sorry to be so cruel. Okay, so we know also evidence-based that people who are obese at their adolescent time, they have much more colon cancer, endometrial cancer, and probably, that's not very sure, probably also it's controversial, breast cancer, but I'll explain you why in another slide why breast cancer. And if we're not talking about all kinds of morbidities, but just all-cause mortality, you can see very well that gaining weight, gaining visceral fat is causing a rise in all kind of all-cause mortality, and people with BMI, for example, of 40 have 2 or 3 times more risk of mortality, all-cause mortality. But we are gynecologists or endo, so we are with the reproductive system. And the reproductive system is also affected by adipocytes. This accumulation of fat causes also inflammation in hypothalamic system, causing activation or early activation, and that's why that's why we approach in obese girls early puberty, also in boys less. We approach, as I said, early puberty and early menarche. Also, the sex hormone binding globulin is also very important because overweight or adipocytes cause low sex hormone binding globulin, and that's causing, of course, higher testosterone and estrogen. And as you can see that the worldwide secular trends in pubertal onset it's in the States, this one, and not in many countries, is decreasing with time. Yes, so in 2015, we had it a poll about less than 10. And also, the menarche is decreasing. The age of menarche is decreasing. And they calculated, it's calculative, of course, publication, that overweight have their menarche 4 months before those who are not. And what is important is another thing. It's called tempo. Tempo, it's, it's time. But tempo in this case is the time from telarche, from estrogen increase, to menarche. And usually after menarche, a few years, 1 or 2 years after, we have already ovulation, which means that we have progesterone, protection of endometrium. But if this time is too long, meaning that there is too much exposure to unopposed estrogen, that probably increases the risk of breast cancer. And another work from USA, 2020, showed that girls in United States, all kind of, from all races and etc., it's the first time they have median age of menarche below the age of 12. That's the first time that they show it. And of course, early menarche, we know, of course, okay, they are also obese, and we know that they are having more problems, cardiovascular problems, and etc. And one topic we didn't talk about is psychosocial and sexual behavior. And those girls who have early puberty, have early menarche, they suffer from many psychosocial problems, like poor body image, depression, 30%, risky sexual behavior. If to have intercourse or coitus before the age of 13 is more than 2.5 times more risky in obese girls than non-obese, okay? And to have many partners as well. And this is a work from Korea, just to see that victims of sexual assault, if you are obese, the risk 3 times more to be a victim of sexual assault, because, as I said, and to have pregnancy and to have termination and etc. And what is interesting is that, of course, you all know that ECOG says that the menstrual cycle is a vital sign, we have to follow it, and etc. This work is Greetings for Ukraine. It's from Ukraine a year ago, and they just checked women, or girls, it's not women, it's girls, that had any signs like PCOS, they have hyperandrogenism, they were obese, and etc. And they looked for another group that didn't have any sign. They're just irregular menstrual sign. They didn't have biochemical androgenism, clinical androgenism. Their hormonal profile in red was normal, and still they have irregular menstrual cycle. Somehow related maybe to adipose tissue only, and inflammation. And thank you for your presentation of PCOS. Of course, I'm not going to talk about, but just remember that if we are talking about PCOS that is 10%, 12%, with increasing obesity, we'll see more and more PCOS, because those adipocytes or fat accumulation causes insulin resistance, and those who are genetically predisposed will see more and more girls with PCOS. And of course, I don't need, okay. So about treatment, we had heard about, but what is, again, sorry, said about my presentation is the lifestyle change. It's very easy to say at an adolescent, okay, you have to make it a healthy lifestyle change, okay? You have to diet and you have to do sport. And how it works, do you think it works? I'm not going to talk about pharmacotherapy and bariatric surgery, okay? So what's going on? We have the Cochrane Library from 2016. And that's the time, as I told you, that they have all the results from the interventional programs, which show so good results. And everybody was happy. And they showed that after 2 years, they follow up 2 years. So at the end of the intervention program, children lose weight. They did a lot of sport because of that governmental support. They eat very healthy food because that was supported to them. But what happened after? They regained the weight. And almost all regained the weight after 5 years. And 30%, third of the people, regained more weight than was before the intervention. So it's not without side effects. Healthy intervention has side effects because and you can see it in this slot plot, force plot, that you see that in the beginning, many of them did better. But after the end, almost all get to the point, to the initial point, and even overcome it. So one who is from my nation, Albert Einstein, said that it's insanity doing the same thing over and over again and expecting different results. Okay, so telling girls just do diet, or my feeling is that when I see an obese adolescent and I tell her, listen, I will send you to a dietitian, at that moment, the word I say dietitian, I lose her. She would never listen to anything because she's frustrated. She did it. So we have to think over, besides pharmacotherapy and surgery, we have to think about different things. And again, that's work from my country. And they looked at people who eat just the same. One eat pizza and the second eat pizza, and the postprandial glucose is totally different. And it depends on microbiome and anything else. So they have said we have to individualize the approach, the dietitian approach, the healthy life approach, okay? And it's also for high-income people, this kind of individualization. And there are a lot of other, but I started low. Okay, so Mama, just few. Okay, and 2 slides. And we have to look for other things. For example, there are evidence that children, or not children, it's also adult people who are not sleeping well, and here we are doctors, right? So they have craving for special food, high-fat food. That's the craving, or very salted food, or snacks. They don't want to eat vegetables. After you don't sleep for the whole night, you won't eat vegetables. And Mediterranean diet, and et cetera, et cetera. And that's very important, that sport or physical activity or using your muscles, it's not just reduce your fat mass, it's also activates the cyclic AMP and causes insulin sensitization. And by that, improving metabolic things. Metabolic issues, okay? So it's not, so maybe for those girls, we say, that's what I'm doing. I don't want you to lose weight, not at all. Don't go to the dietitian, just start to make sport, okay? And we, of course, have the recommendation of American Academy of Pediatricians. It should be 90 to 150. And that's the last one that you were talking, of course, about, that what is so nice in this work, that they were looking for the pathophysiology. They were looking, what is the problem with PCOS? That they cannot change the genetics, but it's insulin resistance, it's hyperandrogenism, and everything, and they just made this. So I'm concluding. So the first sentence, I hope I convince you. I'm sorry I'm so pessimistic. Obesity is epidemics, and it's not going to anyway. WHO is not going to declare that it's finished. No, on the contrary. And it's at the moment, it's more than 20% of children are obese, and probably it will increase with time. It causes a lot of diseases, and as I said, we'll see many diseases in young people that we've seen once only in the age of after 60 or 70. And the early puberty, which is correlated to that, is also has many comorbidities, including breast cancer. We have the menarche early, and it will come more early. They have more psychosocial problems, and the treatment of obesity should be multidisciplinary approach, and it should be something out of the box. We have to think other. It cannot be the same because it's failed. And the physical activity is always good, and regards for my city.
Okay, next we have Professor Matela Day, gynecologist and expert in gynecologic endocrinology, pediatric and adolescent gynecology, contraception, sex education, gender violence, and child abuse. She's also a co-author of a great book.
Too much. Thank you. Dear chair ladies, dear colleagues, first of all, a big thank you to Dr. Stankovic, Dr. Wood, all the organizer of this Congress, in which I am honored to participate with this particular topic. This is my disclosure. And all of you know about vegetarian and vegan diet, but what I want to stress is that they are not only diet, but an holistic approach to life involving ethics and politics beyond health is also an important aspect of personal and collective identity, and that choose more ethical than for health reasons. And especially vegan are a community with a wide use of information and communication technology. Epidemiological data are very variable over time. What we know that during the recent pandemic, there was a shift toward a more vegetarian diets, and also that in adolescent age, vegetarian and vegan are mainly females. So the question is how to take care of this adolescent with competence and without prejudice. And this is the agenda of my small presentation. The first problem are or not consequence on health. And these guidelines regarding the use of plant-based diets conclude that both vegetarian and vegan diet are appropriate also for a child, also for adolescent, when appropriately planned. And the other point is that people who follow vegetarian or vegan diets are people who don't smoke, who don't drink, who use less salt, and that more easily do regularly physical activity. And this is a study just on children and adolescents in order to compare nutritional adequacy with the controls who are not vegetarians, who are not vegans. And as you see, there are no significant difference in hemoglobin, in vitamin, in cholesterol and triglyceride. Ferritin concentration was lower, but without iron deficiency. And the low levels of vitamin D and of riboflavin were similar in plant-based diet and in omnivorous group. And so they conclude no specific nutritional risk. What we have to learn, we have to do a routine nutritional evaluation, checking for protein intake that should be somewhat higher than standard recommendation. Checking for iron-rich foods, especially for fortified food, and for the use of ascorbic acid, because if you want to eat to absorb iron from vegetable, you need more vitamin C. You have to check for calcium fortified foods, especially for vegans, and the intake of long-chain omega-3 fat. And at last, for iodine intake, that it's possible using iodized salt, using cranberry prunes, and especially seaweeds. It's also important to check for the use of supplements, because we know that for vitamin B12, for vitamin D, for zinc, it's very difficult to achieve a correct intake only with a plant-based diet. And so it's useful to make a supplementation. Sometimes also for long-chain omega-3 fat, and a special consideration for adolescent that need creatine, beta-alanine, and other support for their energy requirements. There is another side. Sometimes these diets are not adequate. So we have to ask for the familial support for vegetarian practice, for the refer to online or offline communities who can help the girl, for the use of fortified food and supplements. And another point is that sometimes they use a lot of processed foods that are not so good for health. And the point is, if the girl is not supported, several nutrients may miss, but also some excess is possible. And an example are seaweeds. If you look, brown algae have a very high iodine content, and so they are a potential exposure to excess iodine and also to anti-thyroid effect. And what's about bone health? We have longitudinal study on plant-based diet that say that in general a vegetarian style is useful for bone health. But if we look to more specific analysis, the one that I show you is on adult women, we see that both vegetarian and vegan have low bone mineral density at lumbar spine. We have also a prospective study which collect dietary information and baseline and follow people with different food choice. And what we see, if we look for total fractures in time, we see, for instance, that hip fractures were more frequent in fish eaters, in vegetarians, and in vegans. In vegans, there was also an increased risk of other side fractures. What we have to consider? We have to consider also when vegetarian or vegan diet started in relation to peak bone mass. We have a study on Polish children who see that the bone mineral content is low if in pre-adolescent period a vegan or vegetarian diet is followed. And we had to consider other risk factors, genetics, physical activity, sun exposure, meditation, and so on, in order to do an in-depth counseling about this topic. But why? Is the lack of calcium responsible? Yes, of course, the exclusion of dairy product is important, but the comparison between vegan and lacto-vegetarian diet didn't reveal so many differences. And so what I want to stress is another study who proposed that other nutrients are probably important for bone health in this age. They found a significant variation of 12 biomarkers that if you see are TSH, iodine, selenoprotein, leucine, and also hormones. So probably we have to think about bone health not only considering calcium intake. And what about metabolic disorder? In adult women, we have data that vegan and vegetarian diets are associated with low inflammatory biomarkers in general population, in obese population, and that the risk of developing metabolic syndrome is low, and also in PCOS women that it's easier to weight loss, even if this is on a small number of people. But why? Because the low content of saturated fats act reducing pro-inflammatory cytokines, and the high content of unsaturated fats activate anti-inflammatory pathways, and the diet rich in fibers, in polyphenols, in antioxidant, change the gut microbiota with reduced bile acid, with increase in Prevotella, Bifidobacterium, Lactobacillus, all protecting gut barrier, and what's its particular, with low antimicrobial resistant genes. But another thing we have to consider is that there is a thin line between plant-based diet and eating disorders. The endorsement of vegetarianism is higher among females with eating disorder, especially if young, if with higher education, with low BMI, and with some depressive symptoms. And to be vegetarian or vegan is a risk factor for orthorexia. So we have to ask for weight change, for eating habits, for menstrual dysfunction, and continue our assessment with the body composition, with endocrine test. And finally, another point of discussion is the fact that we must be aware that strict vegans may have concern about any animal-derived products that may be used in their care. So they use the cruelty-free cosmetics that buy mainly online on vegan website. They use creams containing oleogel and not conventional fats. But also for drugs we have to think about, because many will wish to avoid animal-derived products as far as possible, including induction agents in anesthesia, dressing, implants, and we don't know exactly in our drugs where there are animal-derived products. And also our drugs all have been tested on animals during development. And so none of them can be considered fully vegan. What we have to know is that they want to be informed before making compromise, of course. And also the Vegan Society writes that medicine prescribed by doctors are normally tested on animals, and this is unavoidable. But what you can do is to ask your doctor for medicine that possible don't contain animal ingredients. And so we have to know about it. The last point is about contraception. 2 years ago, the Faculty of Sexual and Reproductive Health Care produced a document about contraception for street vegans because, as you know, lactose that derive from cow's milk is present in all currently available contraceptive pills. And also magnesium stearate is present in a lot of our formulation. So we have a choice between lactose-free contraceptives that are IUD, that are patch, ring, implant, injectables. But we know that also latex condoms may contain casein, and there are special vegan-friendly condoms in natural rub gum who are available online. And also for diaphragm, there are special diaphragm with no animal-derived product. And also we know that all contraceptive products have been tested on animals. So we have to be able to discuss with these young people respecting their philosophy, and I think, and respecting their idea of life, because it has important ethical roots. And that's all. That's my conclusion, that caring for vegan and vegetarian adolescents, we must learn about respectful and competent nutritional evaluation. We have 3 red flags: the inadequate intake of fortified food and supplements, the bone health, and the risk of eating disorder. And then we have to check and inform about the animal-derived content of medicine. Thank you.
And now, thank you very much, Metella, and now it's a very big honor for me to introduce Ellen Rom, direi legend in pediatric adolescent gynecology, is a pediatrician from Cleveland, a previous president of FGE, and for many, many years in the board of the Fiji. And the topic is very interesting because a Fiji statement related to nutrition and eating disorders. Thank you very much.
Thank you for being here. And I'm so grateful to Zoran and Paul and everybody who's here, keeping PAG alive and in the forefront educationally and for all of our patients and community, so that together we improve the reproductive health of young people globally. Thank you so much for vesting your interest here. We're going to fly through some eating disorder work. Thanks for the tee-up from Metella. We're going to talk about saving their bones, their bodies, and their brains. And disclosures, thanks to Paula Hillard for this slide. And I'm on the Organon Speakers Bureau. We're going to fly through eating disorder recognition and talk a little bit about medical risks and impact on bone for the restrictive eating disorders. These are from some of my patients. Sometimes we hear this: eating disorders are not a choice that I ever made. Saying it's a choice is incredibly invalidating of the struggle. And another one: I have atypical anorexia. I was always told I wasn't sick enough. This is what we hear. And we want everyone to recognize that the medical consequences of eating disorders can be invisible and go unrecognized even by very experienced clinicians, and that eating disorders, especially binge eating disorder, which is part of our obesity epidemic, can impact every organ system, and especially with restrictive disorders, bone in particular. And everyone looks at this slide and thinks that the girl ahead is the healthy one and the girl behind is the one with the eating disorders. They both have eating disorders. 2/3 of university athletes have disordered eating. When we think about bone mass, we all know that we're supposed to peak at age 30 and then it's downhill from there. But Jerry Linenger, a 40-year-old white man, 6 months on Muir in space, lost 2/3 of his bone mass. And with NASA and exercise physiologists and dietitians and sports medicine, he regained at age 40 100% of his bone. And if some middle-aged white guy can do it, so can the rest of us. And we can help our patients to regain their bone as well. And we know that some of it's genetic, but it's also how we're couching them and making sure that they're not falling off their growth curves. Pediatricians and endocrinologists live by the growth curve. So can all of our PAG colleagues, so that you can look and see when they fell off, what happened then? Was that because they went vegetarian? Was that or vegan without knowing how? Was that because they something changed in their health status? We talk about orthorexia, we talk about REDS, relative energy deficiency of sport, and all of it is about not enough of the right things or too much of a good thing with respect to exercise. And so thinking through a case, Marla is 16. She sees you because she's lost her periods. She's a year-round athlete, and she's had 2 stress fractures already. She doesn't have any eating disorder thoughts, but she doesn't want to gain weight because it's going to impact her performance. She's 160 centimeters, 43.1 kilograms, BMI 17. So what are we going to do to prevent her stress fractures? We want to ask her, how much of your day are you thinking about food or body? Are there areas of your body that really stress you out? Which ones are those? What's the most you ever weighed? How tall were you? When was that? What about the least? When was that? How tall were you? What do you think you ought to weigh? So if you have somebody who's where they think they should be is way below what would be actually healthy for periods in bone and brain, that's a start of problem recognition. And when did their period turn off? Meant sees as a vital sign. And what weight were they? When the weight where they turn off is likely to be the weight where they're going to turn back on. How often are they weighing themselves? Are they feeling guilty with certain foods? Are they calorie counting? Or in the States, we have lots who are fat gram counting. And sensitive question for the hyper exercises. How stressed are you if you miss a workout? That really picks up those hyper exercises. And DSM-5 came out in 2013, so finally we have atypical anorexia. Same physiology as anorexia, just as much deep doo-doo medically, but they haven't lost the weight yet. They may be overweight or obese. Same way with bulimia. They haven't been binging and compensating for at least 3 months once a week. And it also recognized these other things. So if Marla thought she was too skinny, and she has less access to food at home, since she's the pandemic happened, she wasn't going out for fast food, she wasn't eating at sleepovers because they weren't having them. And so what does that mean? Our group, the National Eating Disorders Quality Improvement Collaborative, found this set of patients, and by 2013, DSM-5 created this new diagnosis of ARFID, and it's physiologically identical to anorexia, but none of the mindset. And it comes in about 3 groups. There's the super picky eaters, the ones who have limited appetite or just aren't interested in food. They get mono, they get COVID, they forget to eat. Or the ones who are avoiding either pain, or they choked on a candy and don't want to ever choke again, or they have IBD or something else where they're having chronic belly pain, so they start avoiding eating because they don't want to have more pain. And you can be in more than one of these buckets. Those are just kind of 3 ways to be thinking about it. So we'll have lots of kids with autism spectrum disorder who are also super picky and don't want their food to touch, and then start falling off the growth curve. Physical exam, we have Russell sign, where they're making themselves throw up using a finger. We have lanugo, and we have parotitis and teeth erosions. If you haven't seen parotitis, walk around an American college campus, because all the girls with straight hair with their cheeks puffing out are all your ones who are throwing up. And bone density, we have Z-score, which is your standard deviation for age-matched control data. So with anyone under 20, we don't think about a T-score, we think about a Z-score. That's your standard deviation. And if they're -1, we're already worrying about them. If they're -2, -2.5, they're osteoporotic. And it's that negative net balance between bone formation and bone resorption. We know that increased bone resorption happens with your low estrogen state and hypercortisolemia. And we see this with all of our hyperexercisers underdoing their nutrition. And this is big business in the States. This is a very expensive illness with $17 billion in estimated healthcare costs just from fractures and osteoporosis. Even a 5% increment in bone mineral density in your teens and 20s can make a significant decrease in fracture risk, and a 10% decrease in bone mineral density is associated with a 2 to 3-fold increased fracture risk. So we're thinking about all those factors that increase bone formation and decrease bone resorption to try to impact their state of bone health. So we used to think, thanks to Bonjour and Thanks, that everyone got what they got by age 15 and that it was all downhill. And then Recker found that you were still getting bone deposition all the way up to age 28, 29. And now, thanks to later data, we can actually keep gaining bone after that. It's not all downhill. And as you just heard, calcium and protein matter, estrogen matters, and age is playing against us. And low energy availability gets you those elevated levels of ghrelin and adenopectin and peptide YY that gets you this net anorexigenic effect, and decreased levels of leptin happen with your fat-derived hormones and signal for reproductive fitness that correlates with your bone mass. So what can you do? And if from the back, if you can't see this, says, Mary, you haven't been taking your calcium pills, have you? So this was one cool study where they looked at a vibrating platform with low-frequency mechanical stim as a strategy to increase bone formation in low heart rate bradycardic adolescents on bed rest. And it showed some promising data in children with cerebral palsy. Didn't do so well for elderly adults. We're worried about them falling off the platform. We don't know if a skeleton of youth with anorexia nervosa acts like a young or an old skeleton yet. And so this is under study now. We also get asked by our patients, should we or shouldn't we on hormone replacement? And we know that lots of physicians are doing hormone replacement. And Ann Klebanski's data back in '95 showed that it acts like a bone Band-Aid. Girls who were very low weight and women very low weight anorexia lost 13-14% bone a year on nothing, and the ones on combined oral contraceptives with a 30 or 35 microgram pill ended up keeping their bone. And Catherine Gordon's data showed that DHEA plus birth control pill plus a 5-kilogram weight gain meant that they gained bone. They had to have weight gain to gain the bone. And they felt better with the DHEA. So oral DHEA plus hormone replacement therapy, they acted like a bone Band-Aid. They didn't further lose bone, but the only ones who gained weight. So what can we do? Transdermal estrogen and DHEA plus birth control pill have some value. So those are our options right now. Now, where's the fat go? It's the only place we see it is in their bone marrow, crowding out. That's why they get pancytopenic. First they lose white cells, then they lose red cells, then they can lower their platelets, because the bone marrow gets crowded out of cellular matrix, replaced by the fat cells. So skeletal losses may not fully reverse. Why? Again, because of that abnormally increased resorption with not enough deposition of bone. And teens with premature conversion to those red cells to fat cells may not regain that matrix as much as they would have otherwise. And we know that bone marrow fat can contribute to that decreased stromal matrix that gives your bone strength. Oh, here, for somebody who needed the picture. There you go. And so this is why we want to pay attention to the bone. What if they need contraception? This is another key question we get asked. Very low combined pills, 20 micrograms of ethinyl estradiol, acts like Depo. They lose a little bone while they're on it, or they're just not gaining. 30 and 35 microgram pills, they're still gaining just like controls. And so that when and we don't know the answer with LARCs yet, or any of the IUDs or implants. So when you're prescribing, we want to start people on a 30 or 35 microgram estrogen patch or pill until they hit 20, or maybe even 30. So 30 till 30, and then go down to 20 when they hit 30. So what can we do? Make sure that there's a reason they're falling off the growth curve, and that could be a new eating disorder or their new IBD or something else going on. Think of periods as a vital sign, and think about the role of genetics and where they are in bone density. Get them to exercise, but not overdo it. Help them maintain a healthy weight for them, individualize it, and make sure they're getting their calcium and vitamin D. And if they're brain starved, think and speak clearly and often. If they're depressed or anxious, make sure you're giving them loving limits and boundaries. And if they're manipulative, communicate with the healthcare team, with the parents, and with all providers so that you can keep them not being of harm to themselves. Final thoughts. This is from one of my patients. The eating disorder lives in the gaps. It will find the gaps and split the kid from the parents and parents from the care team. So the more you can stand shoulder to shoulder, the better. The eating disorder lives in the last bite. Thank you so much.
Some minutes for the questions.
Okay. And do we have a last speaker? We have last speaker. Okay. We got Pallavi. So our last speaker, Pallavi Latte, is a consultant at Birmingham Women's and Children's NHS Foundation Trust. She's the clinical lead for PAG and a subspecialist in Urogyne, and on the executive committee for BritPAG, and secretary, now chairperson of BritPAG.
Hello, everybody. I'm quite aware that I'm the last speaker for today's sessions, and the wine is beckoning. So I will try and keep to time, but I won't be surprised if I also hear the alarm bell. So just to sum up, PCOS is extremely common problem. We all have encountered adolescents who have PCOS symptoms. The goals of treatment would be to identify patients with risks for PCOS or who are diagnosed with PCOS, assess them, assess the appropriate associated disease states like metabolic syndromes, and then do symptomatic management. So in consultation, the first thing you do is you explain to the patient what the condition means, and then just gauge how much understanding they have about the condition. Because unless they understand the condition and the implications, they are not going to comply with treatment. You explore what's bothering her, and then you try and address that. It's very important to remember that anxiety and depression, low body image, low self-esteem are extremely common in this group of patients. And we as gynecologists are not very good at addressing the psychological side effects of this condition. So just as the previous speaker had suggested in the day, that we need to signpost them to the correct services. So in terms of addressing hirsutism and acne, the cornerstone of management is weight loss, oral contraceptive pills. Sapropterin acetate can be considered if the pills are not working or contraindicated. Spironolactone is considered if the pills haven't helped or they are contraindicated. 25 milligram daily, and then titrated upwards to up to 200 milligrams daily. If you use Vanica cream, it is not very effective, but just make the patient aware that they need to use sunblock, as if they get exposed to skin, that can cause thinning of the skin on the face. They can use the topical treatment regimes, and of course, again, psychological support of these teenagers who have body image issues is very important. If they are considering anti-androgen treatments or retinoic acid and such kind of treatments, then make sure that they are on appropriate contraception because of the teratogenic side effects. So this is just the summary of network meta-analysis of 37 trials on treatments for PCOS management in adolescents, which showed that there is no statistically important difference among all interventions to improve menstrual regulation or BMI. There is moderate quality evidence to show that hirsutism scores are reduced by multiple interventions that include either single treatments or combination medications, including lifestyle interventions, metformin, OC pills, spironolactone, pioglitazone, metformin OCP combinations, metformin spironolactone combination, and metformin flutamide combination. OC pill result in more dysglycemia compared to metformin. That's not surprising. And in conclusion, metformin and combined pill as monotherapy or in combination with other interventions can reduce hirsutism. None of these medications lead to effective menstrual cycle regulation or weight reduction, effective weight reduction, so to speak. But also remember that there is data emerging that we used to feel that combined pills are very, very safe, but combined pills are associated with 1.6-fold increase in myocardial infarction and ischemic stroke risks, especially in adults, and we don't know what effect they have if they start these treatments in adolescence. As was already suggested, weight loss is achieved with a combination of calorie deficit and exercise, and at least 60 minutes of moderate to vigorous intensity physical activity per day if you want to lose weight, along with some resistance workouts. Minimizing screen time or sedentary sitting time is also important in teenagers. In terms of the combined hormonal pills, the levonorgestrel containing pill seems to have the best of all in terms of giving good symptom relief and having low VTE risk. The previous speakers have already mentioned about the contraindications for use, so whichever criteria you use, just migraine with aura, personal history of VTE, and hypertension is a total no-no for combined pills. We all know what are the alternatives, so I will just skip through this. With the metformin, metformin can be considered in PCOS, especially if they have impaired glucose tolerance and if lifestyle changes have not achieved the desired goals. It is most beneficial in high metabolic risk groups. Patients should be informed that this is off-label, so it's not sort of indicated in, or it is not licensed for this particular use. We increase the dose gradually so as not to give too many side effects, but we are aware that the compliance is low because of the side effects, especially the diarrhea and abdominal cramps. Metformin prolonged use can be associated with low vitamin B12 levels. So myoinositol has been quite interesting in the sense that this is a naturally occurring compound, and it has been shown in adults to be non-inferior to metformin in reducing body mass index, reducing hyperandrogenism, and especially note the fact that it does not have as many side effects at all as metformin does. So the way it works is it's an insulin sensitizer, and there are lots of studies in adults. We wanted to look at what was the available evidence in teenagers. So we did a systematic review of use of myoinositol and chiroinositol in adolescents to see whether they brought about improvement in quality of life and symptoms in adolescents. And we did followed the usual methods that we do for systematic review. In interest of time, I'm not going through the whole systematic review methods, but what we got was 8 studies. There were no RCTs specifically in adolescents. There was one RCT which included adolescents and adults, but the data for adolescents was not available separately. So we were left with 4 cohort studies and 4 case control studies. Varying definitions of PCOS were used. Remember that all these studies were using the Rotterdam criteria, so the newer criteria studies are not available. These studies mostly were quite small size studies, and the interventions were quite varied. So some used 1 gram of myoinositol once daily to up to 2 grams twice daily. We had different durations of treatment between 3 and 6 months. We also had different accompanying treatments. So some studies used alpha-lipoic acid, some studies used folic acid, vitamin C, some used combination of myoinositol with metformin, and some used combination with combined pills as well. So we have quite varying studies, and hence we could not do any meta-analysis. They looked at varying outcomes. Some looked at clinical outcomes like body mass index, weight, hirsutism scores. Some looked at, or a lot of studies looked at biochemical markers. And one study also looked at the ovarian volume post-myoinositol treatment. In most studies, what was apparent was that myoinositol did bring about significant weight loss while the adolescent took the treatment, and it also improved the menstrual irregularities. There was reduction in homeostatic model insulin-resistant indicator, but its effect on other biochemical indicators was variable. So the quality of the studies was quite variable. Most of them were poor by definition because they were case-control studies. And so the conclusion is that we don't have good quality evidence to support its use. And so we do need a robustly conducted double-blind RCT of adequate power to inform how effective is myoinositol in adolescents. We surveyed the WCPAG and the BRITSPAG membership on the practice of treating polycystic ovarian disease in adolescents. And we also sought views on what the clinicians thought were important PROMs, or patient-reported outcome measures. We sent reminder emails 2 weeks later. As is the case with all surveys, the response rate was poor, about 51.7%. 31% were gynecologists, 27% considered themselves to be PAC specialists, and 58% worked at university hospitals. 80% of the practitioners saw about 1 to 5 PCOS patients per month. The clinicians thought that the important prompts, if we were to do a study in myoinositol in adolescents, would be to look at body, facial hair, weight concerns. And 87% of the practitioners thought that this would be an important area of research. These are the treatments that various practitioners gave. Combined pill was a commonest one. And so we are in the process of designing this study from University of Birmingham, and we would look forward to collaboration with some centers in Europe. This is some YouTube videos that we have made, some medical students from University of Birmingham have made to explain to teenagers their condition of polycystic ovarian syndrome. Thank you very much for the opportunity to speak today.